Hi, my name is Dr. Matthew Reddick. I'm a genitourinary medical oncologist at UCLA School of Medicine, and I'll be moderating today's virtual tumor board. I'd like to introduce you to our panelists. First, we have our medical oncologist, Dr. Susan Slovin. Dr. Slovin, please tell us about yourself.
Thank you, Dr. Reddick. I work at Memorial Sloan Kettering Cancer Center in New York. I'm also a genitourinary medical oncologist whose focus has been on prostate cancer with a longstanding interest in prostate cancer immunotherapy and biologics. Thank you for having me.
Hello, I'm Dr. Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GU malignancies.
My name is Jason Abel. I'm a surgeon, the chief of urologic oncology at the University of Wisconsin.
I'm Dr. Tyler Fromm. I'm a radiologist at Washington University School of Medicine in St. Louis. I'm an assistant professor with appointments in both abdominal imaging and nuclear medicine. So I do a lot of oncologic imaging below the diaphragm.
The current case is that of a 70-year-old male current smoker with oligometastatic high-grade muscle-invasive urothelial carcinoma, that's PD-L1 negative, status post-radical cystectomy, and adjuvant gemcitabine and cisplatin, followed by stereotactic body radiation therapy to a pelvic bone metastasis, now has a stable asymptomatic osseous metastasis in the left shoulder. Ultimately, the question will be, what is the next line of therapy? Patient presented with urinary hesitancy, dysuria, and hematuria with a performance status of ECOG 2. The patient has a history of chronic obstructive pulmonary disease, although the patient is not on home oxygen. Hypertension and coronary artery disease are also present. The patient is a current smoker with a 40-pack year history, but no alcohol or drug use, and there is no family history of malignancy. In September 2018, the patient undergoes cystoscopy and transurethral resection of the bladder tumor, a TURBT, with a biopsy of a lesion near the bladder base, showing invasive high-grade urothelial carcinoma with muscularis propria invasion. A CT urogram shows a large volume hyperdense material in the urinary bladder with severe left hydroureteronephrosis. A CT scan of the chest with contrast shows small nodules scattered throughout the lung fields with an irregular soft tissue thickening along the right lung base, felt to be unchanged compared to prior scans. A month later, in October, urology sees the patient and recommends going directly to cystectomy due to the urinary symptoms. The patient in October of 2018 undergoes a radical cystoprostatectomy with pelvic node dissection. The pathology reveals a urothelial carcinoma, high grade, invading the muscularis propria, involving perivesicular vesicular adipose tissue and involving the prostate by direct extension. Lymphovascular space invasion was also present. Margins are negatives, and 4 out of 21 lymph nodes are involved. And the primary tumor is stained and is PD-L1 negative. A CAT scan of the chest, abdomen, and pelvis demonstrates a lytic lesion in the right inferior pubic ramus, pelvis that is, and 2 soft tissue nodules in the left main stem bronchus, concerning for metastatic disease, which we'll look at in a second. The patient is initiated on combination chemotherapy with gemcitabine and cisplatin for 4 cycles. First, Dr. Fromm, could you please review these scans with us?
Sure. So these are CT images on the left of transaxial slice through the lung bases, and I believe this image is capturing what was described as irregular soft tissue thickening. So this was noted on the patient's sort of pre-surgical CT and was said to be stable from prior scans. Certainly would want to know the duration of time over which that finding had been stable. Certainly, this this would be a somewhat unusual appearance for a metastasis. Atelectasis, scarring, organizing pneumonia could all have this appearance in a patient with significant smoking history. A low-grade adenocarcinoma that's sort of very slowly growing would certainly be in the differential as well. So with that lesion in and of itself, I wouldn't jump straight to metastatic disease. In fact, other things would be higher in my differential. Though perhaps there were some other pulmonary nodules as well. We're also told that there were 2 soft tissue nodules in the left mainstem bronchus. We don't have any images showing that finding here. And the implication from the description was that these were presumably new. So there's sort of a differential for that. Certainly a patient with known cancer, would want to rule out the possibility of metastatic disease, but other things, sort of mucus in the tracheobronchial tree can create the appearance of a soft tissue nodule. It sort of comes and goes. Things like mesenchymal tumors arising from the bronchi, carcinoid tumors, bronchogenic carcinoma would all be differential. That'd be something I would just sort of want to look at over multiple scans and kind of get the sense as to how that is evolving over time. But certainly could be sampled by bronchoscopy if indicated. And then on the right-hand side, we have bone windows through the pelvis, and we see a lytic lesion in the inferior right pubic ramus. With some cortical breakthrough, so probably a component of pathologic fracture there.
Turn to Dr. Slovin and ask Dr. Slovin to comment on the chemotherapy, both the regimen that was used and its role in the perioperative setting, specifically neoadjuvant versus adjuvant timing of the chemotherapy.
Yes, thank you. So in general, if we have somebody who has muscle invasive cancer, urothelial cancer, in the absence of metastatic disease, the rationale would be upfront gemcitabine and cisplatin, or if you prefer, dose test MVAC, both of which, well, actually the first one, gemcitabine and cisplatin, are not really showing a survival benefit, but has been extrapolated from the data. The concern about taking out the bladder is really based on symptoms. And I think the goal here was either the patient did not want to undergo radical cystectomy initially, and therefore, there was a lot of hesitancy, and he was finally convinced probably that it might be helpful to him in the setting of relieving his symptoms of perhaps urgency, frequency, and even hematuria. I don't think it was unreasonable to give it in the adjuvant setting. There were nodes, and this has been something that's been under discussion for a lot of years, as whether or not there is a role for adjuvant in patients who have a sizable number of lymph nodes status post cystoprostatectomy. And in this case, I would say it probably does make sense more to deal with not only the possibility of local relapse, but systemic relapse as well.
Okay, thank you. And I'll ask Dr. Abel, although we don't at this point in the storyline know for sure the extent of the disease, given the uncertainty of the metastatic disease in the lung, the bronchus. But if the patient did have a solitary pulmonary metastasis without evidence of disease elsewhere, is that someone that you would consider for a metastasectomy?
I think the data for metastasectomy in urothelial cancer is really, really sparse. I think, as things evolve with more, maybe with more efficacious treatments in the future, we'll get there. But in general, there's very, very little data for solitary treatment of a metastasis or local treatment of metastasis for urothelial.
So in March of 2019, a bone scan shows stable osseous metastatic disease with foci of uptake in the right inferior pubic ramus, as well as a left shoulder lytic lesion in the anterior glenoid. CT of the chest, abdomen, pelvis shows that the stable lytic lesions in the right pubic ramus, as well as the new left shoulder lytic lesion, and tactic radiation therapy to the right pubic lesion to 40 gray in 5 fractions is completed. I'll ask Dr. Patel to comment on the role of this stereotactic radiation therapy to the right pubic ramus lesion, and why that lesion might have been chosen for radiation as opposed to the shoulder met.
I would have to agree with Dr. Abel. We often sort of borrow from the surgical literature to support when to be very aggressive with metastasis-directed ablative, SBRT. So in the case of urothelial carcinoma, I think I agree there are limited data for this. In general, I would say in situations where we want to use SBRT for oligometastasis, I tend to favor doing this either to all known disease or to none of it. If there's a symptomatic lesion that needs treatment, most of the time, conventional palliative radiation doses would be used. So in this case, I'm assuming that the right pubic ramus lesion was symptomatic, given that Dr. Fromm thought there was maybe a pathologic fracture there. Certainly not unreasonable to give radiation there. There are some data that suggest pain control is better with stereotactic approaches, even to bone lesions that are non-spine. So that may be, that we may be extrapolating here for the use of SBRT. But I think alternatively, a standard 10 or 5 fraction regimen, palliative conventional external radiation would be reasonable as well. I would not recommend then additional SBRT for an asymptomatic shoulder lesion, particularly with the uncertainty with what's happening in the lung, and a mainstem bronchus lesion that we probably wouldn't target well with very high dose radiation.
So we'll go back to the main question. The original question is, what is the recommended next line of therapy? So this patient has possible soft tissue involvement in the left mainstem bronchus, has 2 bone mets, one of which has received SBRT. So I'll ask Dr. Slovin to comment on further therapy in the context of the patient having received adjuvant cisplatin and gemcitabine.
It always poses a challenge when patients fail conventional approved chemotherapy. I think the biggest problem we face right now is that I don't know if we have any genomic profiling on him, because I'd be very concerned about whether or not certain more targeted agents might be helpful. For example, FGFR or the nectin, so that, for example, one could have erdafitinib as a possibility for more targeted approach, or enfortumab. I mean, there's a lot of things that can be done, but of course we just don't have the information available at this time. Giving as a second line chemotherapy drugs like paclitaxel or docetaxel or adriamycin are really going to be a very, very limited efficacy, and in some cases even 5-FU. I think it would be very reasonable to consider any or all, actually, of the checkpoint inhibitors. We have sufficient data for the anti-PD-L1 and anti-PD-1 drugs, avelumab, atezolizumab, and the like. So all of them, any and all of them can be used. What concerns me more is that he does have a history of COPD. I don't want to call him quite a vascular path at this point, but remember, these are not lightweight drugs. In fact, nothing that we do in oncology is really lightweight, and this would require really very, very careful monitoring, lest we see a pneumonitis or anything else that could be potentially life-threatening. I would probably recommend that a biopsy be done either of one of the bone lesions or even endobronchially, just to confirm that we're dealing with the same cancer that we started out with. There are roles for ablative therapy with lasers for endobronchial lesions. So there's still, again, multimodality approaches. So it all is not lost at the present time. I would say it's more along the lines of, let's make sure we're dealing with the same disease that we started out with before we make an educated guess about how to go forward.
Thank you. So I think if there are no other comments, we'll summarize the case. So this is a patient with likely metastatic urothelial cell carcinoma, who seems to have progression after platinum-based chemotherapy. There is a recommendation to consider a biopsy of one of the metastatic lesions, if feasible, to confirm the diagnosis. And systemic therapies could include a checkpoint inhibitor, such as pembrolizumab. I should point out that even though the primary tumor was PD-L1 negative, there can be discordance between a primary and metastatic PD-L1 expression, especially in urothelial cell carcinomas. Additionally, somatic next-generation sequencing is appropriate, especially to try to detect an actionable mutation in one of the FGFR isoforms, FGFR2 or 3, which would render the patient eligible for a FGFR inhibitor. So those are the various options and recommendations for this difficult case.
And Dr. Reddick, I want to add, always think of a clinical trial.
Excellent, thank you. So please do refer patients for clinical trials, especially when systemic options are somewhat limited.